Good evening, everyone. At the outset, I would like to thank ISA Bellarian team, WIMS Alumni Anesthesia Academics for giving me this wonderful opportunity. Okay, so now that we are aware of anatomy of liver and pathophysiological changes in jaundice, let's go ahead with obstructive jaundice and its anesthetic management. What is obstructive jaundice? It is a type of jaundice where there is block in the biliary tree, preventing the normal drainage of the bile into the intestines. So the patient presents with right upper abdominal pain, fever, jaundice, pruritus, dark colored urine, clay colored stools, loss of appetite, weight loss, hepatomegaly, and in advanced cases, portal hypertension, splenomegaly, and ascites. What are the causes of obstructive jaundice? Extraluminal causes include malignancies of liver and pancreas, metastatic lymph nodes, pancreatitis, periampullary carcinoma. Intramural causes include congenital atresia, sclerosing cholangitis, benign strictures, tumors of the bile ducts. Intraluminal causes include foreign bodies, parasites, and gallstones. These causes can be classified into intrahepatic and extrahepatic also. The most common cause of obstructive jaundice is choledocholithiasis. What happens when there is increase in biliary pressure? There is disruption of the tight junctions between the hepatocytes and the bile duct cells, causing increased permeability of the bile into the liver sinusoids. If this obstruction is not relieved, there is neutrophilic infiltration, increased fibrinogenesis, collagen deposition, obstruction of sinusoids, development of secondary biliary cirrhosis, and portal hypertension. Also, this acute obstruction may increase the hepatic arterial blood flow while there is no change in portal venous blood flow. Chronic obstruction causes decrease in the total hepatic blood flow, dilatation of sinusoids, and elevation in portal pressures. Obstructive jaundice has significant effects on various systems. Hence, caution should be taken while administering the drugs. Preoperative investigations. These are required to confirm the diagnosis, optimize the patient, and for guiding the anesthetic management. Complete blood count. Hemoglobin. It is generally reduced in patients with malnutrition, malabsorption, malignancy, increased catabolism, parasitic infestations, inflammation. Total leukocyte count is increased in hepatitis, cholangitis, sepsis. Platelet count is reduced because of decreased thrombopoietin, and also there is platelet dysfunction. Liver functions are done. The enzymes that are specific for cholestasis is alkaline phosphatase and gamma glutamyl transpeptidase. There is increase in total bilirubin as well as direct bilirubin. The serum albumin levels are reduced, globulin levels are increased, and there is reversal of albumin-globulin ratio. Because of defective gamma carboxylation of vitamin K dependent clotting factors, the PT-INR APTT is deranged. If there is associated hepatocellular injury, aspartate and alanine transaminase levels are also elevated. These patients have reduced glycogen reserves, hence prone for hypoglycemia, hence a random blood sugar is advised. Some patients may have renal impairment, hence renal function tests are done. Other tests that are required are blood grouping and cross-matching, viral markers for hepatitis B and C, chest X-ray, ECG, echocardiography. Ultrasound abdomen and CECT are required for confirming the diagnosis, to know the cause of obstruction, level of obstruction, and the involvement of intravascular structures. Now, based on the history and investigation, prognostication of these patients are done using PIT score. There are 8 parameters involved. Each parameter is given a point. If the points increases, the mortality rate also increases. The parameters involved are type of obstruction, point is given if it is malignant, age more than 60 years, serum albumin less than 3 gram percent, serum bilirubin more than 10 milligram percent, serum alkaline phosphatase more than 100 international units, serum creatinine more than 1.3 milligram percent, total leukocyte count more than 10,000 per cubic mm, and hematocrit less than 30%. The three independent risk factors determining the perioperative prognosis in these patients are preoperative hematocrit of less than 30%, indirect bilirubin more than 200 micromole per liter, and malignancy. Now, there are certain consideration in obstructive jaundice we need to know before going ahead. Hepatic blood flow is affected. Pharmacokinetics profile of anesthesia-related drugs is altered. Hepatic dysfunction and hepatic elimination is altered. There is encephalopathy because of hyperbilirubinemia. These patients may be posted for endoscopic retrograde cholangiopancreatography, Whipple's disease, Whipple's surgery, or any other unrelated emergency surgeries. So the goals that we need to have is to maintain adequate hepatic perfusion, maintain oxygen supply demand relationship in liver, maintain renal perfusion, meticulous fluid balance, minimize physiological insult to liver and kidney, appropriate choice of drugs and doses adjusted depending on their effect on hepatic blood flow and metabolism, avoiding hypotension, sympathetic stimulation, hypoxia, pressure effects, and hepatic venous congestion. What are the preoperative instructions that the patient needs to follow? We advise for high protein, high carbohydrate, low fat diet to improve the glycogen reserves. Nil per oral status for 8 hours for fatty meal, 6 hours for non-fatty meal, 2 hours for clear liquids prior to surgery. Maintenance fluid therapy can be started to avoid fluid deficit and hypotension. Antacid prophylaxis with proton pump inhibitors and metoclopramide is given. Generally, preoperative sedatives and anxiolytics are avoided to prevent the postoperative cognitive dysfunction. If anxiolysis is necessary, use short-acting IV benzodiazepines like alprazolam, lorazepam, and oxazepam. Consider vitamin K 10 mg OD for 3 days for correction of impaired coagulation. Correction of anemia, hypoalbuminemia, and electrolyte imbalance is to be done. Treat if there are any infections. Use prophylactic antibiotics. Avoid nephrotoxic drugs like NSAIDs, aminoglycosides. If the total bilirubin is more than 8 mg%, use mannitol 0.25 to 1 gram per kg of 10% to flush the renal tubules. Blood sugar assessment should be done. Written informed consent explaining due risk as per patient profile for anesthesia, blood transfusion, invasive monitoring, postoperative mechanical ventilation, and ICU requirement is taken. OT is prepared with standard ASA monitors with protocolized machine check, appropriately sized ET tubes, laryngoscopes and airway adjuvants are kept ready, forced air warmer, fluid warmer, rapid infusion devices are kept, anesthesia drugs and inhalational agents are kept ready, DVT stockings for thromboprophylaxis is used. The intraoperative monitoring includes standard ASA monitoring, including electrocardiogram, non-invasive blood pressure, pulse oximeter, temperature monitoring, and end-tidal carbon dioxide monitoring, along with urine output monitoring, neuromuscular monitoring, blood gas monitoring, and bispectral index. If the patient has chronic liver disease with hepatocellular dysfunction or is posted for a major surgery involving major fluid shifts, invasive monitoring with intraarterial blood pressure, placement of central lines, arterial blood gas analysis, and thromboelastography may be used. Based on the type of procedure or surgery, patient may require sedation, regional block, central neuraxial block, or general anesthesia for the procedure. Regional blocks are generally avoided if there is coagulopathy. For major surgeries, general anesthesia and regional analgesia is preferred. Coming to regional blocks, drugs commonly used are lignocaine, bupivacaine, ropivacaine. These are highly protein bound, metabolized in liver and excreted in the kidneys. Hence, reduction of doses up to 50% is required. Lignocaine is 60 to 80% protein bound, has high extraction, hence depends on the hepatic blood flow, metabolized in the liver. Hence, these patients have increased half-life to more than 300%. So, reduce the dose of lignocaine. Additives like fentanyl, morphine, buprenorphine at reduced doses can be used. Central neuraxial block. High spinal and epidural anesthesia causes reduction in mean arterial pressure, further reducing the hepatic blood flow. So, smaller doses of the drug and slow injection should be practiced. If there is reduction in mean arterial pressure, it should be reversed with fluids and vasopressors to restore the portal blood flow. Caution should be taken while giving vasopressors as they may further reduce hepatic blood flow. Epidural analgesia is safe and analgesic effect are potentiated with use of opioids. Coming to general anesthesia. Since multiple drugs are used in general anesthesia, it is of utmost importance to know the pharmacokinetics of these drugs. Protein binding, redistribution, effects on hepatic blood flow, extraction ratio, redistribution, and excretion. Coming to intravenous induction agent. Intravenous induction is preferred to inhalational induction, as intravenous anesthetics have only a modest impact on hepatic blood flow. There is no adverse influence on post-operative liver function when BP and cardiac output are adequately maintained. Propofol is preferred. Its induction dose should be titrated to achieve loss of verbal contact. It is safe in hepatic disease as the pharmacokinetics and dynamics are maintained because of extrahepatic metabolism. Propofol increases total hepatic blood flow, spasmodic vasodilation, and increases oxygen delivery. It also acts as an antioxidant and recovery profile is good. Other preferred IV induction agents are etomidate and ketamine. It can be used in patients with cardiac instability. Ketamine has little or no effect on hepatic blood flow. Thiopentone is highly protein bound, metabolized in liver, and has longer elimination half-life. Hence, titrated doses should be used. Inhalational anesthetics cause reduction in cardiac output and mean arterial pressure, which further reduces the hepatic blood flow. All inhalationals decrease the hepatic arterial buffer response in a graded manner. It is least with sevoflurane. All inhalational anesthetics are metabolized in lung with certain percent, 20% halothane undergoes liver metabolism. Sevoflurane is about 2 to 5%, isoflurane is about 0.2%, desflurane is about 0.02%. Halothane is avoided as it decreases the hepatic blood flow and oxygen delivery, decreases hepatic arterial buffer response. It has a risk of arrhythmias, a risk of halothane hepatitis, which has an incidence of 1:7,000 to 30,000. Obese female are at higher risk, and exposure to halothane in the last 3 months increases the risk. Coming to nitrous oxide, it is safe. It decreases the MAC of the inhalational agents, but it should be avoided in cases with intestinal obstruction. Coming to opioids, remifentanil is the preferred drug as the pharmacokinetics is unchanged. It is metabolized by the blood and tissue non-specific esterases. It has short context sensitivity half-life. Fentanyl is also preferred as it has no effect on hepatic blood flow or oxygen consumption. It is highly lipid soluble and undergoes rapid distribution. Dose needs to be reduced and titrated. Sufentanil is also considered safe. Pharmacokinetics is not altered. Alfentanil is highly protein bound and has prolonged half-life, undergoes extensive metabolism in the liver, hence reduction in doses required. Morphine is generally avoided in decompensated liver disease as it is elimination is delayed because of reduced hepatic blood flow and extraction ratio. Accumulation of active metabolites can be seen. Biliary excretion is affected. These opioids may cause spasm of sphincter of Oddi, but the incidence is low, approximately 3%, which can be treated with atropine, naloxone, glucagon, and nitroglycerin volatile anesthetics. Coming to neuromuscular blocking drugs, cisatracurium and atracurium are preferred as it undergoes non-specific ester hydrolysis. Cisatracurium has an added advantage that the metabolite laudanocin is only 1/3 of that produced by atracurium at equivalent clinical dose. And there is no dose-dependent effect of histamine release and no cardiovascular adverse effects. Vecuronium, pancuronium, and rocuronium are generally avoided as they are highly protein-bound, metabolized, and excreted in bile. But if warrants administration, the maintenance doses with neuromuscular monitoring can be administered with dose titration. Succinylcholine choline can be used for rapid sequence induction, but care should be taken as there is decrease in plasma esterase levels may cause increase in duration of action of succinylcholine. Also, patients are prone for bradycardia and arrhythmia. Reversal agents. Sugammadex is the agent of choice for reversing the steroidal neuromuscular blockers, as it is not protein bound and does not undergo hepatic metabolism. Neostigmine dose is unaffected in hepatic dysfunction. Use caution to prevent serious arrhythmias. Other drugs that can be used are dexmedetomidine, though dose should be reduced. Tranexamic acid and epsilon aminocaproic acid can be used to reduce the bleeding. Coming to ventilation strategies, maintain eucapnia 35 to 40 mmHg. Avoid large tidal volume and high airway pressures. Avoid hypoxemia, hypocapnia, and high levels of PEEP, which reduces the hepatic blood flow. Coming to fluid management, balanced salt solution to be used and urine output of 1 ml per kg per hour is targeted. Goal-directed fluid therapy is given. Crystalloids are used initially. Add dextrose to prevent hypoglycemia. Colloids like 5% albumin, 6% hydroxyethyl starch is used. Blood and blood product transfusion. Mannitol diuretics like furosemide and vasopressors like dopamine if urine output is less than 0.5 ml per kg per hour even after fluid challenge. Coming to perioperative analgesia, the requirement of analgesics is generally reduced because there is increase in endogenous endorphins and enkephalins levels in these patients. Epidural is generally preferred. Bupivacaine 0.0625% is used for continuous infusions with opioids like fentanyl 1 to 5 micrograms per ml or morphine 25 to 30 micrograms per ml at 5 to 10 ml per hour. IV paracetamol can be used at reduced doses and liver function should be monitored. IV fentanyl patient-controlled analgesia can be used. The doses should be reduced to half. It can be used in compensated liver diseases. Regional blocks like intercostal nerve blocks, tab blocks, paravertebral blocks can be used along with local infiltrations. NSAIDs are generally avoided as it has a risk of GI bleed, platelet dysfunction, and nephrotoxicity. Coming to postoperative management, postoperatively, patients are watched for delayed recovery and worsening liver function. Stable patients who are conscious have adequate neuromuscular recovery, hemodynamically stable patients. Normothermic with adequate pain relief patients should be extubated and monitored in high dependency unit. They should be supplemented with oxygen, IV maintenance fluids, adequate analgesia should be provided, DVT prophylaxis, early immobilization, and early identification of complications like sepsis and postoperative jaundice is done. Patients may require post-op ICU if they have prior poor functional status, high fluid shift intraoperatively, and less than 0.5 ml per kg per hour urine output. If there is ongoing metabolic acidosis, hemodynamic instability, and need for vasopressor use, prolonged duration of surgery. If the patients are unstable, IPPV is continued. Sedatives are discontinued early to assess neurological status. Fluid and electrolyte imbalance is corrected. Maintain normothermia. Urine output of 1 ml per kg per hour. Maintain adequate analgesia. Use of antibiotics and blood product transfusions if required. To enhance the recovery of these patients, certain guidelines are followed. Those are ERAS guidelines. Preoperatively, adequate counseling and education is given. Patients are advised for exercise. Medical optimization is done. Oral bowel preparation is not done. Preoperative carbohydrate loading is done. Fasting guidelines are followed. Patients are pre-medicated and thromboprophylaxis is given. Intraoperatively, epidural analgesia is preferred. Minimal invasive approach for surgery is preferred. Use of antimicrobial prophylaxis, adequate periop fluid management, prevention of hypothermia. Postoperatively, early removal of NG tube and urinary catheter, providing good postoperative analgesia, early oral intake, early mobilization, and prevention of postoperative nausea and vomiting improves the patient recovery. These are my references. Thank you.